So welcome everyone to QI Connect, our third session in 2021 and our 66th session since we began. I'm Ruth Glassborough, Director of Improvement at Healthcare Improvement Scotland, and I'm your QI Connect Chair. So QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. And all of our speakers on QI Connect give of their time freely for the benefit of health and care services, something we very much appreciate as it enables us to offer this as a free event. So welcome to QI Connect. I'm now going to pass over to Jess, who's going to tell you how it works and how to use the Q&A function today to submit your questions for our speaker, Becca Malby. Jess, over to you.
Thanks very much, Ruth. Okay, I'm just going to take you through some housekeeping slides just on how live events works. So it's different from a regular MS Teams meeting in that it does not allow for the audience to use cameras or microphones, only the presenters, so the audience can't be seen or heard. At present, it's not possible to interact with other attendees via chat, but you can upvote by liking any submitted questions you see in the Q&A, and I'll come over to the Q&A function in a wee second, that you'd particularly like to see put to the speaker. Just to say, we're going to have two Q&A sections today, so there'll be one in the middle of Becky's main presentation and then there'll be one as normal at the end, so please get your questions in plenty of time to be moderated. So because they'll be moderated, it will take a minute or two for the question to show up in the live chat. So this session will be recorded, and by taking part you consent to this, and a recording of the session and resources covered will be made available following the session dates. In the event of any technical issues, please bear with us and we'll work hard to bring the session back at the earliest opportunity. So the Q&A, if you look at the top right of your screen, it's the sort of the speech bubble with the question mark in it. And when you click that, that brings up the Q&A panel. So you can submit your questions using the text box shown, and they'll show up in My Questions tab. And then once they're approved, they'll show up in the featured panel. And you can like your favourite questions. So if you see something you particularly like to see put to Becky, then you can just like that and that will bring it to Ruth's attention quicker. And a summary of any resources covered will be made available along with the recording after the session. Thanks.
Thank you, Jess. So as well as health and social care staff across services in Scotland, we now have over 1,300 organisations who link into QI Connect, including 89 universities and colleges. And some of these organisations are based in other countries. We now have 65 countries represented in our QI Connect community. Due to time differences, many of them will be watching this via the recording. But for any of you who are joining us in person from other countries, please do feel free to flag if you're asking a question where you're joining us from. So delivering QI Connect is very much a team effort. So a big shout out to the amazing team that works so hard behind the scenes to deliver these sessions for you. And thanks, as always, to the NHS Scotland National Video Conferencing Service, who continue to provide us with excellent support for these MS Teams live events. So make sure you follow us on Twitter, and I am delighted to announce that our @HisQI Connect Twitter account, which we lost access to last year, has finally been recovered. So please remember to tweet as you learn using the hashtag #HisQIConnect, and if you're not already following us, please do follow us. So I'm delighted today to be introducing our speaker, Professor Becky Malby. I've seen what she has in store for us today, and this is going to be another fantastic session. Becky is a professor in health systems innovation at London South Bank University, where she leads the Health Systems Innovation Lab. She's an experienced manager and thought leader in health and social care, and she has a track record in systems innovation, co-production, leading networks, organisational change and leadership development in the UK and internationally. She's on the advisory board of a number of national change programmes. She's a visiting fellow at Stellenbosch University in South Africa, as well as a nominator for the Ashoka UK. She's also, and I don't know where she finds the time to do this, but she's also an active community leader whose activities have included setting up the Ilkley Sewing Scrubs, a wonderfully named group, a local sewing group in Ilkley that produced scrubs and face masks during the pandemic. And she's a passionate campaigner for cleaning up the river in Ilkley. She is known to be an energetic and enthusiastic leader of change and a forward thinker. And I am sure you're going to experience that for yourself firsthand this afternoon. So with no further ado, Becky, over to you.
Thank you so much. I'm just going to share my screen, and thanks so much for that introduction. That was incredibly generous of you. What I'm going to talk about today is primarily around UK health services, but I hope you will really be able to connect with it internationally. And I think if you are going to tweet this and you've got international comparisons that are helpful, I'd really like to see those. So please do carry on doing that during the course of the session. I'm going to do this in two halves. So the first half is really context. You can't design services without understanding context. So I want to give us enough time just to sort of set the scene about where are we, why are we where we are, and then start working on what can we do about it. And particularly then in the second half, looking at networks as an organising form that could probably meet the needs of complex needs of our local people, but also serve the needs of organisations and professionals. And I really want to do that by tying that into some of the lessons from the pandemic, though I think we may be a little sick of those, so I'll probably skip over those a bit quick. So there's sort of three phases to this presentation and to our session today and to our experience in the UK over the last year, I mean, particularly in England, which was this early spring surge of COVID, the autumn surge and the winter very long surge. And those were characterised by very different phases of response by the NHS and very different phases of energy. And I want to just bring that to bear really as we had a growing understanding from the pandemic of the capability of our NHS. It sort of put it into stark light. So what of course happened in that very first surge was we had a very, very clear purpose. And that meant that we could organise very, very quickly around need. Now we did a study on called 10 Leaps Forward, and we did a study about what was going on that worked well. Of course, there were things that were terrible, and I'll share some of those. But where things were going well, what were the key features of that organisational response that made it possible to respond proactively and quickly around this emergent, shocking, exhausting and scary pandemic? What were we able to do well? And the reason why I want to go through this is because what we managed to do, where we did it well in this time, is so important for what we do continually over time. So it isn't a that happened then. It's a that was possible then. Let's keep making it possible conversation. So the first thing we saw were this was surveys of NHS staff, managers and professionals across primary and secondary care. But the first thing we saw that staff were being properly valued and supported. And that meant that, a nurse said in her response, I'm not just a nurse, I'm a nurse. And she was so proud of that. And actually, for those of us that are professionals, clinical professionals, in health services, we get so much from recognition of the work we do, and somehow we had so little of that. And actually what it showed us during this time was how much recognition you need to do a good job and to see you through very difficult times. So what people really appreciated was this being valued, and because it made it much easier for professionals to do the work. And the value was about well-being in the workplace, people being provided with food, proper collaborations, a more balanced day, flexibility around work, including online training. Somehow everybody just sort of reframed and went, hang on a second, our clinical professionals who are making these difficult decisions, trying to do the best they can, they have to be a big priority for us. And it was so important that they were right centre stage. This has clearly drifted a lot, which is why I want to pay attention to it. 20th century tools, well, you know that, the digi stuff and stuff like technology always sticks. So that's definitely stuck. So 21st century tools, engage leaders. Let me just share with you whilst I'm talking a story. This is from one of the NHS chief execs of a hospital. And what was really interesting listening to him was him saying that I've done my best work in this time. I feel a bit guilty about it because I've actually managed to just get rid of all that stuff that seemed to get in the way of the job I came to do. I have been able to properly serve my staff and my community. I didn't feel alone. I have confidence. I was way out of my depth on what was happening in terms of the pandemic, everybody was, but I could just bring my best management skills to the fore. And that really surprised, you know, that's a shocker, I suppose, that it took that for a chief exec to be able to do his, at that time, best work. And the fourth thing in that category was that the basics were sorted. You know, we just managed to sort out in the NHS, which is phenomenally bureaucratic for a purpose, but we managed to sort out data sharing. We managed to make decisions in the right time. We hopped on Zoom to sort stuff out very, very quickly in that time. We streamlined loopholes in referrals, massive reduction in paperwork for discharge. Those things, suddenly, all the things that had apparently been critical, business critical, were moved out of the way. So we had this really interesting issue that we sort of just sorted stuff so that we could get on with the work. And then we got into, so having sorted stuff, what did we see? Well, we saw a more joined up local health system. People could collaborate because the purpose was incredibly clear and was shared. This is really important for any collaborations and networks, being clear what you're in it together for. There was much more flexibility. There was no sense that, you know, within any high performing health system, you have to cede territory. Well, people ceded territory really quickly. All that discharge to assess stuff. For those of you that are international colleagues, this is how we get people out of hospitals into homes. And for people who need some sort of support, you know, we can't agree who does the assessment. Basically, that's what it boils down to. And yes, at this time we could agree. And actually, whether somebody from a social care background or somebody from a physiotherapy background did the assessment, suddenly it didn't matter. Whereas it had mattered for years before in some systems. So there was much, much more collaboration, really brilliant working together as teams. People checked in. How are you? How's your day? How are you coping? What's going on? Because everybody had a very difficult personal context as well, whether it was having COVID, relatives with COVID, looking after kids at home, homeschooling, whatever it was, just the anxiety of having to isolate or to disconnect from people that you know and love was incredibly stressful. And so we acknowledge that stress in a way that we haven't done before. There actually was in primary care some headroom at that time to think ahead. Teams were clear what they were doing. There was protected time to check through. How's today going? Is today going well? Is there anything else we can do? So there was learning. And that meant that professionals really stepped up. What's really interesting about clinical professionals working at their best, where they work at their best, they scrutinise each other's practice based on real-time data. That's not a norm in the NHS, but it is a norm in high-performing health systems. I know in Scotland you've got a grip on this in a way that we haven't in England. But actually there was this sense of being in it together and learning together, and that was an international phenomenon. And then we saw that we could get into a system that was based on needs and where we could think much more proactively. There were signs of anticipatory care planning. Prevention suddenly got on the agenda, even if it was temporarily. People say, hang on a second, how come people who are black and brown people are struggling in the way that white people aren't? What's going on? It began to emerge that there were some patterns here. I'll share some more of those with you in a minute. We saw citizens and patients as partners co-making decisions. There was some fantastic work in primary care with GPs dialing into people's homes where their families were there, seeing their context through Teams, Zooms, whatever the platform was that they were using, being able to have proper conversations, sharing data, saying, well, what have you done? You know, I'm going to send you an oximeter. What's your oxats now? Let's have a look at it. Let's talk about it together. How are your kids? So actually, some of those consultations were in a context that was better for everybody, that felt like there was more shared decisions. One chap told me that he was able to just WhatsApp his GP and say, I just need to, I think I can reduce my meds for depression. I'm actually feeling more in control at the moment. And the GP say, yeah, let's just check in tomorrow. Absolutely fabulous responsiveness, collective working around making shared decisions. So patients seen as partners and community collaboration. My sewing scrubs, I guess, was one of those, but lots of communities stepping in, particularly around those folks who are lonely and isolated, trying to find ways to connect with them, answering phones, being volunteer talkers, being able to just check in on people and do their shopping. There was amazing. The assets of the community were recognised and used. And of course, as you know, for those of you that are in this country, there were some horrendous things that happened as well, particularly around PPE. And what people said, never let services go back to Monday to Friday. We never let us forget that citizens have assets to bring. Never bring back face-to-face appointments unless we absolutely have to, for outpatients particularly. Never forget that we can learn together, that GPs and hospital doctors can talk, whatever the trust says. Never forget that. Well, what happened? So what happens is when we did our best work in the pandemic, actually what we had were a lot of the characteristics of high performing health systems. Absolutely clinical leadership was properly supported by professional management. There was shared decision making with patients and families. There was better integration. Professional cultures were supported. Information was provided to enable people to make decisions. We engaged citizens in their care and the design of their care. We really thought about how do we secure robustness in our primary care teams. This is stuff that's not new. This is 2011. This is Jean-Louis' work looking at Intermountain, Jönköping and Nuka. But all of that sticks. So we saw this in the NHS for the first time, I would say, persistently in many places. So then what happened? So let's have a look at the next surge. Did we do that again? Which of those 10 leaps had stuck by the time we got to October? Well, it turns out not much of it. How fascinating that the things that are stuck, that's that sort of dark purple line. The stuff that stuck was the digitools. There was something, but as you can see, everything was slipping. So look here, we had seen a lot of community collaboration right up at the 90%. What are we seeing by October? Under 40%. We lost that huge asset that was helping us as the NHS. What have we done at the time? We'd said to people, we can't manage. Can you help? And the community have gone, yeah, absolutely, we can. We love the NHS, we want to support it, but actually we want to support our local communities. There was a connectedness, a local connectedness that we've started to see drift. Now, when you look at but the worst thing here is staff being properly valued. So having gone from people saying, yes, we felt valued, that was at about 70%, we're down to 20% of people reporting feeling some sense of value. Now that for me is very, very concerning, because if we can't make these really critical things stick, when we've had an experience of it, when we know we can do it, that's pretty shocking. And what I've seen in terms of certainly some of the national bodies' response, and not Scotland's, but the national bodies' response to this, what I've seen in the reports is we're a learning system now. Well, I'm sorry, that's not actually. So I'm really interested in the so-called reset strategies. There's masses and masses of stuff going on, but here are some things where what our clinicians said, these things really mattered. They made a huge difference to effectiveness and outcomes. Why aren't we doing something about it? So let's have a look at what we were learning at that time, not just the fact that we were not managing to make some of these cultural changes stick, but at the same time we were surfacing some patterns. And what we saw was that Black and brown people were really struggling with COVID in a way white people weren't, and that was in Marmot's view completely linked to structural racism, which led to those people having much poorer living and working conditions than white people in this country. So absolutely huge, it was starkly obvious, and something that the NHS needed to address, because obviously if that's the situation, what have we been doing about it? And I want to talk to you about this thing called universal healthcare, because obviously at the outset of the pandemic, NHS was for everybody. free at the point of delivery, everybody had equal access. Well, what this showed was that we don't. So when we look at mortality across from the least deprived to most deprived, look on the far left, the most deprived mortality rate is at 800 on all causes. COVID's at around 200. You look at the least deprived, it's at 400, tipping onto 400, and around COVID it's 100. That's half the mortality, depending on how deprived you are, for all causes and for COVID. COVID was following the graph for no matter what your conditions are, your likelihood of being ill and dying. I mean, that's phenomenal, isn't it, as a graph? Marmot's had that 2020, it's something that we've known. But when it's presented like a graph like that, it's a bit easier to go, it's a bit difficult, that, isn't it? You know, when you start looking at the funding patterns of the most deprived and the least deprived, what you find in local authorities is that they have had the most stripping of their assets and their funding, look at the Marmot report, than the least deprived. The percentage decrease has been enormous. So we keep hitting these communities. So poverty is a really big deal in this country, and it leads to illness and death. Now I want to talk about the NHS's response to that. So let's start talking January to April. We start seeing these patterns. They start showing up that this is a real problem, and we start talking about it. We get to January and February. What are we doing about it? So what's the problem? What are the patterns that we're seeing, both in that response to our survey and in what we're seeing in the patterns of COVID? So the response, i.e. staff's experience, and what we're seeing in terms of our population's experience of COVID. What are the patterns? Well, here's one. One thing that is the pattern is that we need to look after our staff properly. Actually, one of the things that I think we've not got a real framework on is our ethical response to harm. Now, people, we saw the damage, the horror that our clinicians were dealing with in some parts of the NHS over the course of the pandemic, and we witnessed it. It was all over the telly. But actually, people are witnessing that, not at the amount of deaths. That was shocking, particularly for our junior staff. But we're witnessing harm and horror and death on a regular basis in the NHS. And on the whole, you have to sort of get on with it as a clinical professional. What I'm not seeing at the moment, collectively and systemically, is a response to harm. How do we support people who have been engaged in moral injury? How do we move to moral repair? There was actually quite a lot of discussions about this. The wellbeing work in trust is beginning to pick up. But for me, there are some things that we really need to do about this, and they feed into some of these national reports about learning systems. When I see the learning systems report, I don't see any of this. And the link is things like Schwartz rounds, is bearing witness, is doing a whole system response. So if we've seen people have had really difficult, exhausting and horrific experiences, firstly, they want it to be witnessed. Secondly, they want to be valued for it. Thirdly, they want to discuss it and make sense of it. And fourthly, they want to learn, and that it happens in that order. And so, something like Schwartz rounds, where you can bring people together from a whole system, because I was hearing GPs say, we understand this is happening in ICU, but we don't feel it and see it and touch it in the same way. You might say now GPs are really overwhelmed. The hospital isn't feeling, seeing or touching it in the same way. We have to connect our system around this and saying, just because one bit of the system is experiencing this, we can't say it's their problem. It's a collective sense. We're in it together. So we have to bear witness to this together. You need the integrated care system folk in the room, as well as the community trust, as well as the PCN, as well as the GPs, as well as the ICU doctors. And we have to hear the stories together, and storytelling is really, really critical around this. So let's move on to, so that's the first piece, is that we've got to do something about how do we properly focus on the well-being, the repair of staff, and how do we properly value them by being honourable about their experience and their experience on a day-to-day basis. And then I think the next piece is that that we have these issues in our society, and we're prepared to feel really sorry for everybody, but we're not prepared to do much about it. And I think the NHS has been somewhat complicit in not providing universal health care to people who are poor, primarily poor, but it turns out those are also people who are primarily black and brown. So I think the NHS has been complicit in the lack of universality in healthcare in 3 ways. The first way is in medicalising poverty. The second way is not being overt about how it's rationing. And the third way is by making people come to us rather than going to them. And I'm sorry if this sounds really harsh, because I know you've had really difficult experiences, but I'm saying this because if we don't turn the heat up now and rethink this, the NHS is going to keep on doing all the stuff that made it worse in the first place. And that just can't go on. And one of my experiences that is around the vaccine, which I'm going to share with you in a minute, about our inability to get onto the proactive footing. And our leaders have to get proactive now. They can't sit here persistently being reactive about this. So this is the work we've done with a lot of general practices. Some of you might have seen it if you've seen our work in primary care. When we ask GPs and nurses in a general practice setting, of the people who turn up frequently, what is their context? Are they in control of their context? Are they struggling with their context? Have they, are they absolutely out of control? They've got very poor control of their context, or you just don't know. And as you can see, 41% on average in any general practice of people that turn up frequently are struggling with life. Now, social prescribing is one of the solutions to that, isn't it? But what I'm really interested in is how we're not saying this. So if this struggling with life is primarily related to poverty, and a lot of it is, what are we saying about how many folks are turning up in the NHS because of the knock-on consequences of being poor? Because being poor makes it impossible to live a healthy and well life, or that being poor means that you need help, and the only help left is in the health sector because there's nothing in social care left. Whatever it is, we are sticking plastering poverty at the moment by persistently providing solutions. Some of those are still GP appointments that help people hang on, but we're not being overt at the same time. And I said this at the Royal College of GPs 2 years ago now. Why aren't we saying how many GP appointments, how many people in A&E are turning up with the primary causal issue is poverty? Because actually that means we're not dealing with it in the place that's it's best dealt with. Why aren't we saying that? So at the moment, I think that's a really big deal, that we can't deal with the problem until we're open about what the problem is. So we can keep on managing people's diabetes, etc. So for instance, very interesting, I don't know if you know this, but by 2035, the NHS spend on diabetes is going to be 16.9 billion if we carry on now. It's currently 9.8 billion, which is a quarter of this spend. The entire spend of our defence budget in this country is spent on diabetes. A quarter of the entire defence budget of this country is currently spent on diabetes, and by 2035 it's going to be over a third. That's work by the York Health Economics Consortium. Now, if that's the case, what is causing that level of diabetes that is going to take that much? Now, I would like, how much of that is about people's ability to be in control of their lives? Question. So here's the second one, which is rationing. So what happened, of course, is that at the time with NHS, with our workforce at a considerable low compared to need, that what we've had to do is just not provide stuff. And it's not clear to people who need to access the NHS whether they can get it or not. So we're not being open about the impact of the pandemic on cancer treatments, on MS diagnosis, on long-term conditions, on complex care nurses checking up on old people and frailty. We're not clear about that, neither are we measuring it. So what we know is that waiting lists have gone through the roof. We know that, but we don't know the humanity issues around the fact that what we've done is deny some people access. We have rationed, and we have rationed based on what? In a transparent way? In what sort of way have we rationed? So rationing is happening, but not in a way, for me, that's overt, transparent, publicly accountable, in a way that the public owns the NHS. It needs a say in this. Here's the third thing where I think the NHS is being complicit about the lack of universality. So it's not universal in terms of rationing, because we are providing some things for some things and other things we're not providing, and we're not clear about it. So some people with some conditions just aren't getting what they need. And here's the last thing, which is the so-called hard to reach communities. So when we talk about people who are not accessing healthcare or not getting what they should get, what we're hearing is this language around hard to reach. And Fatima is a fantastic community leader. She worked with the CCG and her family were the last out of the Grenfell Tower. And she's done a fantastic TED talk, if ever you want to listen to it, absolutely brilliant, about the power of communities. Now, that's what we found, is that you can't reach people, except when we want to vaccinate them. And look what we did. We put on Ramadan twilight vaccination clinics. We did women's only clinics. We did different language things. We have vaccine taxis, vaccination buses, pop-ups here, pop-ups there. When we want to reach people because we think we need to support their health needs, we go out there in the most creative and innovative ways. Why aren't we doing that for diabetes? Why aren't we doing that for some of the other things? What happens is somebody who's very poor with kids is looking at her budget and she's trying to work out, she or he, how to get to the diabetes clinic, let's say, or to an appointment to hospital to check something that's gone wrong with her eyesight. And it's going to take 2 or 3 buses, kids in tow. That's going to cost her money and time. She's got to think how she's going to feed the kids at the same time, or he is. And that looks like a whole day outing because it's 3 bus journeys to get to that clinic. Well, you don't go, do you? You don't go when you're tired and you haven't got enough money to pay your electricity bill. And yet, so why are we expecting people to do that? Because that is creating discrimination. Okay, so when people are hard to reach, we treat the process and we do a big comms thing. You know, we stick posters up in bus stops. And we do some sort of incremental change. When we see people as easy to ignore, when we recognise that we've ignored people, we get into providing where people are. We do innovation and co-production. So when we're thinking about universality, in my sense, I'm just keeping on the time. When we're talking about universality, we've got to really design healthcare to meet needs, which means we have to step into the shoes of those folks. In general practice in England, I know that we're not providing services to age 7 to 24. They're going to out of hours or not going at all. We're providing masses to our older population. Now, everyone, you know, we're being paid per head. If you're providing primary care services, you ought to be providing the per head money to those 7 to 24-year-olds. Our young people have been really struggling during the pandemic. They've had a pretty short shift of the whole experience. And they're getting the same with the healthcare. So when we're talking about young people and anxiety, schools are really anxious about this. How are we reaching out and managing that? So our future of healthcare is in living well. It's not just in treating disease. So what if our health sector's purpose was making life worthwhile? What if we started there? What might that do for us in terms of thinking about how we design health services universally? So I'm going to stop there for a second for questions. And I'm going to stop my sharing whilst we just take questions for a few minutes before I move on to networks.
Great. Thank you, Becky. And there's a lot of comments in the Q&A box that are agreeing with much of what you've said, particularly around that slipping back, around looking after our staff. And there was so much in there that you've covered already that is so thought-provoking. The shorts around at a system level. Are you aware of anywhere that's doing that?
No, why not? Someone do it. It needs doing. So yeah, there is a hospital I'm working with that's starting that. I think there's some anxiety around. You also don't want to create a level of PTSD by getting people to talk about stuff they've not recovered from enough. But yes, one of the hospitals I'm working is just stepping into that space now. But they also were the hospital that made sure that all their juniors took at least a week off, that moved them back into work very slowly, that mentored them very tightly. You know, it really thought about how to move out of that acute phase over the winter into the next phase, particularly for the juniors. It's been very caring.
So that might be one we want to learn from. I don't know if you're able to share which one that is.
I'll have to ask them.
Okay, great. But if you are willing to share, we'd love to put that out on Twitter. And then we have a question related to that, which is somebody who is wondering if regular high quality clinical supervision could support the repair of moral injury. And they're highlighting it's something that's been provided within family nurse partnership programme, and that the evidence is showing that it's helping clients and nurses to stay emotionally safe.
I think it also really supports that professionalism piece. So, you know, I think professionals at one level have let themselves be infantilized by a management and contracting process that tells you what to do, rather than you saying, I need, you know, you should be screaming for data now as a clinical professional and saying, in order to make decisions, you know, so I would say most clinicians have no idea about how poor local people are, what their circumstances are, what the best, you know, I've worked in so many places where there's very little understanding, real-time data in front of clinicians on which to make decisions, not just on a population basis, but on an immediate basis, with in terms of, you know, what's the best treatment, what's the best way, how we organise, what's the best theatre to needle time, all of that you'd expect to see. And I think if you've got really great clinical leadership, all our medical directors, our nurse directors, you should be absolutely focused on getting real-time data into frontline teams. Every high performing health system has a data scientist supporting clinicians. We don't see it.
We don't. And I loved your thinking there about how do we name this issue about poverty in primary care, and how do we, and again, is there anywhere that's doing that we could learn from?
The people are, it's interesting, isn't it? Because I don't know why, it's like it's a bit naughty to talk out of school. It's what it feels like, which is why, you know, because actually people, you know, general practice really does want to look after its community, but you could do harm by doing what you think is good. So it's a bit like, you know, sometimes you have to, if you don't surface it, it can't be managed. And actually what people in general practice, we just want to care for folks. And so I don't think it's my job, that poverty thing up there, I don't see it. But I do think that's ICS and PCN's jobs to do. I really do.
And that would be in the English system, the ICS, in the Scottish system, yeah. That would be our integrated
regional tier, whatever the regional tier is.
In that context. Yeah. Becky, there is so much richness there. Would you mind carrying on? Because I'm conscious of time, and we don't want to miss out in what's coming next in your presentation.
Okay, here we go. Do let me know if anyone's disagreeing, because you know, it's awful if people don't agree. Then we need to hear from them too. Otherwise, I'm in a little echo chamber.
So if anybody disagrees, please do highlight. But at the moment, they're all agreeing.
Okay, so let's have a look now about how do we proactively lead, because this is the critical point. When if you look at the vaccination issue that I was sharing, one thing that really struck me was that in February it was obvious you can't have GPs vaccinating and looking after people with complex clinical needs. The people with complex clinical needs were keeping a bit stum, weren't they, and hanging in there waiting for it to go. So of course their needs were going to escalate radically as of now, and of course we still needed to vaccinate the entire population. So why on earth didn't we work out how we were going to do that when we did have some headspace to do it, when there was a breath? We got all caught up in heroics, because actually the public likes being rescued, the heroicism of vaccinations, the heroicism of ICUs, rather than the professions need to own the fact that our jobs are actually about pain and suffering and holding people's hands as they're dying, and you know, and helping people with bad backs, you know, get out of the chair and wiping people's bums. We do that stuff. That's what we do. And actually, that is the heroic stuff. You know, running in there with a vaccine, absolutely, of course, war effort equivalent. We all need to do our bit. But the reality is vaccines should be being given by volunteers, lay peoples, people coming out of retirement, auxiliary staff. It's not high. It's not a GP salaries job. It really isn't. And so if we haven't sorted that out, we haven't recruited the admin, we haven't recruited the people to do it, and suddenly GP workloads are through the roof. We have to get proactive here, and we have to do that collaboratively. It isn't just for a GP to do. The system needs to work around how we're going to do this, because it's in everybody's interest. So we don't need to just rebuild the ship each time. We sort of need a fleet. When we're going to do anything that's around complexity, we have to do it together. You can't fight the contract for general practice around care homes on your own. You have to go to the care homes, the geriatricians, the regional tier, and say, is this contract fit for purpose in terms of what we all want to do for meeting the needs of people that live in care homes? So stop fighting bits, start working together on needs-based process. Now, what happens is that when we need to work together, somebody puts in a structure, somebody puts in an organization, and this is like, this is AD 66. This poor guy was ordered to commit suicide for being a troublemaker because he said, you know what, we just meet every new situation by reorganization, and it creates the illusion of progress, but it produces confusion, inefficiency and demoralization. And I'm seeing that now again and again. We're going to have integrated regional tiers, primary care networks. And actually, if we're not careful, we lose the plot about what it's for. Because we are in this transition, we're feeling it. That old world was biting back actually with that slide I showed about what isn't sticking. The hierarchy it saps life out of us because we use it so inappropriately. Our class system saps life out. We are the most centralized democracy in the Western world. And we have to become more decentralized. We have to share power more. We have to become more local. We have to become more networked. And we will be, because the whole world is moving that way. We're just spitting blood about doing it at the moment. So collaborations work as networks. Collaborations work where there's clear shared purpose and there's a clear need for the work, where we have data to understand what's happening now. I don't know about you, but I observe a lot of healthcare meetings where people talk about, this is what we need to do because, and you say, how do you know? Well, because I know, because my position, because I know, because of my experience. Where's the data? What's really going on around here? How do we know what's happening? Back to my young people, when I go to general practice, you say, are you meeting the needs of your whole population? They'll say yes, and then you look at the data and find nobody under the age of 24 is turning up. Did you know this? No, that's surprising. Well, they obviously don't want to come. We have to understand what's really happening now, because you can't design a service if you don't. So that data I was showing you from general practice is not universally gathered by every general practice. It's just not. And yet, why not? It's really important that we find out what's happening. And we don't do that because power is in holding the story. That if I know, knowledge rises to the top. If you know, that means it delegitimizes my role further up the hierarchy. But in networks, we're in it together. It's not around expertise at the top. It's around collaborating based on what sense we can make of what's happening now. We have to understand all members' needs and meet them. We need to make a difference and we need to learn. And this is why networks fail. They fail because we haven't reached a common understanding about why we're in it together. We don't have a plan. It's all here and now, back to the vaccination. There's over management of the relationship, so it predicates some people over others in the network. We over expect network members' ability or willingness to contribute to the network. We think some members are better than others. We constrain network members' independence. There's a lack of trust between members. We don't recognise when leadership needs need to change. We don't recognise, we don't have enough story about impact, about what the network's doing. Those are the things why networks fail. So you can see already that as we describe things like primary care networks or integrated care networks or integrated care teams, you could already see, I think, probably some of those issues there. What are we in it for? We're in it for because we're told to be in it, rather than in it for around common purpose. So networks really, really work well where we're in this domain of work. We're in the do better things. There is a role for mechanistic control. There is a role for hierarchy, which is that doing things well. That's the sort of, making sure that the worst doesn't happen when you're amputating legs or when you want people to be paid. Those are the things you need to have in the mechanistic world. Most of our stuff is in the doing better things worlds. In the improvement world, where we're having a participative relationship, including with citizens, that's usually around some level of incremental change. Networks are usually in that space for learning. In the doing better, where we're trying to co-produce, networks are for delivery. So we're looking at learning networks in that middle phase, collaborative delivery networks in that doing better things phase. And it's just remembering that you need all of these things in any organization sometimes. So it's always about the work. It's not about the structure. What's the work? And if we're in that relational complex world where it's so complex that nobody really knows what to do, where you have to collaborate, then you're in a network for delivery. Then you need social care, healthcare, mental health, the person, the community together to solve the problem. So it's really being clear when you're in a network who should be there. And then it's thinking, the other piece around who should be there is around acuity. I've just popped this up because what we find in high performing health systems, they've sort of got this a bit better organized, which is they understand what level of need is best served by what mix of professional and organizations. So where you have, where things are not very complex, where there's more transactional care, or people need continuity, then they've got a level of complexity, but you could deal with it in the practice or in the primary care or in the community team. Then the work stays there. But there becomes a point where somebody's care needs are getting more complex, and you need help. And you might need help, let's say, from mental health services, and then it's better for primary care general practices to be working together to together relate. Let's take those young people issues at school. Those young people might be going to different general practices in a patch. You might then say, actually, as a primary care network, we can work together to understand those young people's needs, to co-design them with them, and to work with our mental health services together to think about how we best meet those needs. And then we get into that higher complexity around specialist care. And the reason why I say this is I don't know whether you do this, but I'm struggling. If you've got an example, send it to me because I'm desperate to find it, where it's really, really clear that the acuity tips you into the work at the next level of the tier. So what I see is that primary care networks work is often around something around contracts, rather than it's around complexity or it's population health needs. And it's not tipped around the nature of what's going on. So let's try again here. That within general practice, bottom left, people who are struggling with life, they need to have a good community, and the general practice can work with them. They might need support to manage their health, and the general practitioner might work with them with a social prescriber. That's still in the domain of the general practice. They might be at the point where they've got complex needs, but they just need regular appointments with the GP and the nurse and and somebody in the practice. And so they just need, a half-hour appointment every month. My parents are in that domain, really. They could do with a complex care nurse on a pretty regular basis rather than 101 10-minute appointments every week, which is what they get. They just need some continuity. And then it gets to the point where they're not, they've got to the level of instability where they need something else. And that's the point where you need a multidisciplinary team and so on. It's this piece that I don't see mapped out well in a health system. But if we're going to generate networks for delivery and for delivering care, then we need to know at what complexity do we need a network. If you look at Intermountain, this is their mental health integration. When you look at what they do, they're really clear about that acuity tip. They really understand that clinical workflow. They have fantastic information systems really pointing at that and saying we've got to the point at which we need to tip this person into the next nature of collaboration. It's really, really good work there. And they've radically reduced A&E admits by doing that. So data-driven awareness, collective action has to come out of a level of data. And so if we don't have that data, we can't both make good decisions, and also we can't really hold the space for people to act well. So one of the things that we saw in the pandemic is that the chance, I suppose, to reimagine our learning systems, to bring ourselves together. So let's say we were clear about need, and we were clear about why we were in it together. Let's say we had a shared purpose that was about meeting people's needs at a level of complexity that we can make sense of. Let's say we had data about that. Now let's say we could design those around people's needs, just keeping that universality picture in mind. Then if we were going to do that, what would the service look like? And it starts with this notion of having a clear purpose. Are we really clear for whose benefit our efforts are being made? What is our purpose together? Do we have that clarity? And I don't see a huge amount of discussions about this, but it's absolutely critical for networks. Are we clear who's in the network? So when we're getting to that higher level of complexity, for instance, if we don't involve citizens themselves in that network, we will never get the gain that you're seeing here, which is that when we find that people do better at managing their own health where they have friends, Torbay spent a lot of time helping people have social connections. Look at the self-report visits to GPs dropping by 32%, massive improvements in wellbeing. If you work with communities, you understand their needs and you bring their assets into the network too. So those are the effective network characteristics that I've talked about a little bit earlier. It's really got to address big needs. It has to meet your members' needs. It needs strong relationships, but it must develop helpful outputs. On our website, you're going to get this anyway. We've got a maturity matrix that'll help you work out where you should be paying attention in terms of your network. But as proactive leaders, I think your effort in leading any network proactively to meet complex needs that have surfaced during the pandemic, that demonstrate the underlying dynamic of how we aren't providing universal health care, then we have to sustain our team, we have to meet needs rather than demand, we have to collaborate where we're interdependent based on complexity, and we need to find a new collaboration with citizens and patients.
Thank you, Becky. And there was just so much richness there and so much to provoke thought and questions. And I know I've got so many thoughts going through my mind on the back of all of that. Thank you. We're going to start our second question session with Joanna Swanson, who is our guest questioner today, who is Head of Health Protection Division in the Population Health Directorate at Scottish Government. So Joanna, over to you.
Thank you, Ruth, and thanks, Becky. That was brilliant and just so thought-provoking. My question is this: I attended a meeting recently where the speaker asked everyone as part of the check-in how things were with them at that moment, and the word that appeared at the centre of the resulting word cloud, huge in the middle of it, was exhausted. So my question is, how can we support and uphold each other to care, to collaborate and to innovate when so many of us are so tired?
I suppose that back to those patterns, symptoms, patterns and generators, what makes us tired. Some of what makes us tired is the fact that what in front of us is a tsunami, that no one's dealing with it. Now, you know, there are a lot of people in the NHS paid over 100 grand, a lot. You know, they're going to sort some of this out. So what I'm seeing is like a scattergun of initiatives, so many initiatives, rather than some very basics, which is what are we here for and what should we be doing? So the first thing for me is that all those people doing transformational change, learning systems, blah, 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 let's focus on a couple of things that really matter. Have you seen the priority list for the NHS at the moment? It's pages long again. You know, where can we really focus our effort that'll make a difference? That's the first thing. That's the job of a leader. If the job of a leader is not to produce 100 priorities for people at the front line to do, the job of a leader is to work out what really matters and to do that publicly in accountability with communities. So that's the first thing. The second thing is that if somebody knows that what we see is the problem, what we see is massive demand, nowhere near enough staff, a lot of staff with long COVID, and we just go, oh my God, and people themselves just worn out and we don't know what to do. And so it makes you exhausted just thinking about tomorrow. I've heard people say, I get into work and I'm already hyperventilating with a level of panic about today. Now that's horrific, absolutely horrific. So a leader's job is to create some calm in that mess and say, we know, we hear you. Here are some things we're going to do, because you know in your most exhausted and horrific times that 10 minutes can be really helpful. I'm not belittling I'm not saying 10 minutes is the answer, I'm just saying, but remembering the check-ins, remembering the huddles, the things that we did do in the pandemic when we were busy. How are you? How are things? Let's make sure, you know, my team, we check in every day, every morning, every day, because we're doing it like this. How on earth do we stay connected if we don't? There are some things that are about healthy teams that don't take masses of time, but generate energy, help people calm down, help people take a breath. Let's just think about how we're going to do today. What we're going to do is we're going to care for each other whilst we do it, you know, so prioritizing the well-being of each other, paying attention to that, looking after yourself as best you can, making sure that we don't sit on this all day, and you at least have 5 minutes to walk somewhere, to do all those things that are small things, but that really help. I've been really horrified. We're running a master's program. Everyone say we haven't got time to do it, and you're saying, and people want to drop out, and you say, do you know what? The one thing you could have achieved this year, because work's too busy. Well, it'll always be too busy. So that's the first thing. And the third thing is that where we did have windows, we haven't used them, and so crikey, we've got to use them every time we get them. Back to the GPs, the vaccination. We've had time, and there was definitely time a year ago, definitely time in primary care where there was a bit of a pause. And I said, you must differentiate your list. Go through your list right now, work out who needs continuity, work out how you're going to bring people back. Think proactively about this, and we are not on a proactive footing, and that needs leadership to put us on a proactive footing.
Great, Becky, thank you. And I'm going to slip in one more question, conscious of time, and it kind of builds on some of that and a lot of what you've been saying, which is that many managers and leaders are deeply threatened by letting go of control and getting into the uncomfortable discussions. This behaviour, though, is often not confronted. Emperor's new clothes. Thoughts? The questioner asks.
Well, it's interesting, isn't it, about, you know, I do think this is very tied up with our class system, and, you know, we're seeing a real attack on that at the moment. I think we have to pull efficacy and accountability down to local level. I think we have to hold some leaders to account, because it's very hard to cede territory. It's very hard to give up. I absolutely get that, but you know, the best place to start is around the work. So if you're going to do, you know, if you're going to work on complex stuff, let's say everyone's always working with frailty, but let's say you're going to tackle mental health with young people, then I think you have to call your leaders to account to help you with stuff and say, this is what we need from you, rather than wait to be told what we're allowed to do. You know, I think we have to say, this is my domain of work, and I need this. And my understanding is that it's sort of your job to help me do that. And so I do think we have to flip it around and be a little bit more. That's why I think data really matters at a local level. I think if you've got data, you can start calling your leaders in to help you do the right thing. It makes it more overtly transparent. But all the time it's cloak and daggers, and it's aboutism, and it's who says. You don't have a hope. You don't have a hope. So making things more transparent might help. But at the end of the day, we're moving that way anyway. It's a bit of a societal issue.
I love that response, Becky, and you know, that question comes up at a lot of our QI Connect sessions about the leadership and how do we support them to let go of control. And I think you're the first person who's actually flipped it and said, how do we take account for asking for what we need from our leaders? But as you say, the data is so important there, isn't it? It makes a big difference. I mean,
you mentioned the river campaign, but you might know that it's now in front of the select committee. There's huge task forces around sewage and rivers. What we did was we held people to account. We got the data about what was going on, and then we held public meetings, and we called the agencies in and said, this is what we know. Tell us why it's like that. You know, we're the public, we're taxpayers, so we own it. And I do think there's something about take your place and require things.
Yeah, fantastic. So we've run out of time, unfortunately, because I think we could have gone on for another hour at least on this. Thank you so much, Becky. That has been such a thought-provoking session, and I know I'm going to be watching it back again because there's so much richness of content there that I want to relook at and think about further. I also love the way that you were so focused on the data and so focused on the relationships. It's the both together, and often you get folk who are one or the other. So thank you very much, Becky.
Thank you. I'm having a quick look through the chat, through the Q&As now. It's good. I'm here seeing some really good examples, so I'm gonna somebody send me the Q&A afterwards so that I can follow up with these people. Great.
We will, and you'll notice that David Grayson is in there and has joined us from New Zealand as well. So hi to David, a friend of QI Connect and a friend of Becky as well. So moving on to next time, just to let you know, hopefully we're going to see you all in June for a session with Professor Amy Edmondson. So as many of you will know, Amy is an international thought leader in fields including psychological safety and extreme teaming. She's a very sought after speaker, as are all of our QI Connect speakers, and this promises to be another insightful and thought-provoking session. So we really hope that you manage to join us in June for Professor Amy Edmondson. And just to remind you that the rest of our back catalogue is available for you to watch and enjoy on our website, or you can visit the QI Connect YouTube. Thank you.